Hi everyone, welcome back. In my first video on COPD, I went through its pathophysiology and clinical features. In this video, we'll wrap up COPD by learning about its treatment. Let's get started. So let's start with a quick recap about COPD. It's a very common and serious respiratory condition. In the US, it accounts for more than 100,000 deaths per year, and it's the third leading cause of death in the world, so it's a major global health issue. It's defined as chronic respiratory symptoms, which are mainly shortness of breath and cough. It's associated with an obstructive lung pattern on spirometry. Remember, COPD is an obstructive lung disease. Most of the time, it's due to smoking, and there are two main subtypes: emphysema and chronic bronchitis, which affect different parts of the airway. But there's a lot of overlap, and most COPD patients have features of both of them. So when it comes to treatment of COPD, we don't need to worry about emphysema versus chronic bronchitis. The treatment is just focused on COPD itself and the two main problems that are caused by COPD, which are airway obstruction and lung inflammation. So a major part of this treatment is by medications, and that's going to be most of this talk, but also there's non-pharmacological measures that are important, so we'll talk about those at the end as well. But first, we're going to start with the medications we use to treat COPD. So let's talk about the medications we use to treat COPD. A general good rule to learn pharmacology is to identify the problems and then find a solution to make that problem go away. And as I just mentioned, in COPD, there are two problems. There's airway obstruction and lung inflammation. So to take care of the airway obstruction in COPD, we use drugs that are going to dilate the airway, and so we call these bronchodilators. And to take care of the inflammation problem, we use drugs that are going to suppress the immune system and shut down the inflammatory response, and these are glucocorticoids or corticosteroids. So the punchline here is that the two main classes that we use for treatment of COPD are bronchodilators and corticosteroids, and we're going to learn about both of them. Let's start with the bronchodilators. So to learn how these bronchodilators work, we need to understand how the autonomic nervous system regulates the bronchi smooth muscle. So let's begin with the sympathetic nervous system. Remember, this is our fight or flight, running away from the scary bear. So here the ligand is epi, and it's binding to beta-2 receptors on bronchi smooth muscle. This beta-2 receptor is a GS type G protein, so it stimulates adenylate cyclase to make more cyclic AMP, and then cyclic AMP activates pKa, which inhibits myosin light chain kinase, and this causes relaxation of the smooth muscle, so the endpoint of this cascade is bronchodilation. So now let's compare that to the parasympathetic nervous system. This is our rest and digest, so we're relaxing. We don't need to work hard on dilating our airways. The ligand here is the neurotransmitter acetylcholine, which binds the muscarinic or M3 receptors on the bronchi smooth muscle. This M3 receptor is also a G protein, but it's GQ, so the signaling is going to be different. It's going to stimulate phospholipase C, which cleaves PIP2 into IP3 and DAG, and the result is a rise in calcium levels in the cytoplasm, which is then going to cause smooth muscle contraction. So the endpoint of this cascade is bronchoconstriction. So the net effect on our bronchi smooth muscle is determined by the relative balance between the beta-2 receptor bronchodilation pathway and the M3 receptor bronchoconstriction pathway. So to tilt the balance towards more bronchodilation and less bronchoconstriction, we can either stimulate bronchodilation by using beta-2 agonists, or inhibit bronchoconstriction by using muscarinic antagonists. And so these are exactly the two classes of bronchodilators that are used in COPD and asthma: beta-2 agonists and muscarinic antagonists. So let's learn about these two classes of bronchodilators. First thing is that the route of administration for both classes is inhalation. That means the patient inhales the medication, it enters their mouth and goes directly into their airways and lungs. And this is good because the drug is being delivered directly to the bronchi where it's needed, and there's very little systemic absorption. So this also minimizes the side effects of these drugs. The most common method for inhalation is a metered dose inhaler, or MDI. It's basically a handheld puffer, and it's very effective, especially when it's used with a spacer, and it's pretty easily portable. You can just stick it in your pocket and take it with you. The one problem is that it's very technique dependent. You need to time pressing the puffer button with inhaling just right so that it can actually get into your airways. So in patients that can't do this technique, like in babies or patients in respiratory distress, this one can be hard to use. So in those cases, a nebulized nebulizer will do the trick. So here the medication is basically poured as liquid into this little cup, and then it's aerosolized by high flow air or oxygen that comes out from a tank through this little tubing that's attached here. But again, this one is preferred for people who can't use the MDI effectively. So either way, the main takeaway is that both bronchodilator classes are administered via the inhalation route, delivered straight to the airways, either through MDI, more common, or nebulizer for those who can't do the MDI effectively. All right, so now let's learn each class of bronchodilators. The beta-2 agonists selectively stimulate beta-2 receptors. They cause relaxation of bronchi smooth muscle and bronchodilation. As you just learned, their route is via inhalation, so either MDI or nebulizer. And the way that the bronchodilators are categorized is based on their duration of action, and we have two classes. We have the long-acting beta agonists, aka LABAs, and they have a longer duration of action, but their onset of action is slower, so they work slowly, but they last long, and a commonly used LABA is salmeterol. And then we have the short-acting beta agonists, aka SABAs, and these have a shorter duration of action, but they have a pretty immediate onset, so they get to work right away, but they don't last as long as the LABAs, and the most commonly used drug here is albuterol. Now, the main side effects of both LABAs and SABAs are going to be sympathomimetic. This means activation of the sympathetic nervous system in different organs, and that's because there's a little bit of the medication that can be absorbed systemically and cross-react with other beta receptors. The more common from these symptoms are tremor, anxiety, and tachycardia, but remember the systemic absorption is pretty low, so overall these symptoms are rarely clinically significant. All right, so now let's talk about the muscarinic antagonist. The mechanism here is competitive inhibition of muscarinic receptors, which is going to inhibit smooth muscle contraction of the bronchi and allow for bronchodilation. You may wonder, why don't we have M3 specific drugs like we had for the beta-2 agonists? And one of the main reasons is that because of their chemical structure, it's actually not as easy to create a drug that can selectively bind M3 over the other subtypes of muscarinic receptors. So the drugs in this category are considered general muscarinic antagonists and not just M3. But since their route of administration is inhaled, as we've talked about, their primary action is going to be on the muscarinic receptors that they're going to encounter, which are the M3 receptors on the bronchi, airway, smooth muscle. And the good news is that these muscarinic antagonists are categorized exactly the same way as we did with the beta agonists. So we have two classes. We have the long-acting, which are known as the LAMAs, so long-acting muscarinic antagonists. And just like we saw with the LABAs, these have the longer duration of action but slower onset. And the main drug here is tiotropium. And then we have the short-acting muscarinic antagonists, so SAMAs. And again, just like we saw before, these have a shorter duration of action, but much faster onset. And an example of this one is ipratropium. Now, the main side effect of both the long-acting and short-acting muscarinic antagonists are going to be anti-muscarinic because of their mechanism of action. The most common symptom is going to be dry mouth because of the local effects of the medicine. Now, if the mist is accidentally sprayed into the eye, it can actually cause excessive pupillary dilation, aka mydriasis, and lead to something called acute angle glaucoma. And then finally, while rare, systemic absorption can exacerbate constipation and urinary retention, especially in patients who already have a history of these problems. But just as we said with the beta agonist, the systemic absorption here is low as well, so these side effects are rarely clinically significant. So before we finish with the bronchodilators, here are a couple of mnemonics to help you remember the names. Beta-2 agonists end with terol, so salmeterol and albuterol. Muscarinic antagonists end with tropium, so ipratropium and tiotropium. And then the short-acting drugs in each class begin with the earlier alphabet letter. So albuterol is short-acting, starts with the letter A, versus salmeterol, which is long-acting, and ipratropium is short-acting versus tiotropium, which is long-acting. All right, so we're finished talking about bronchodilators. Now let's talk about the other class of COPD medication, which are the corticosteroids. So corticosteroids are very powerful inhibitors of the immune system. That means they're going to dampen the inflammation that contributes to COPD, and this is why they're part of the treatment regimen. Now, the corticosteroids are classified differently than the bronchodilators, not by duration of action, but by route of administration. And the more commonly used are the inhaled corticosteroids. These usually come as an inhaler, so their effects are localized to the airways, not systemic, just like we saw with the bronchodilators. And the two common drugs here to know are are fluticasone and beclomethasone. Now, they don't really cause systemic side effects. Their main side effect is oral candidiasis, also known as thrush. And the link here is that if this medicine is not inhaled properly, it's going to deposit in the mouth and it's going to affect the oral mucosa, making it more susceptible to infection by candida. And so the way to prevent this is by using the inhaler with a spacer to help deliver the medication more effectively into the lungs, and also rinsing out the mouth after each use. And the other category of corticosteroids are the systemic corticosteroids. Common medications here are prednisone, which is oral, and methylprednisolone, which is IV. These systemic corticosteroids are going to be absorbed into the body and reach higher concentrations inside their target cells, so their effects are going to be much stronger. But this also means that when they're taken long term, they're going to cause a very serious set of side effects, which is known as Cushing syndrome. And these are things you've learned before when talking about cortisol, such as insulin resistance and diabetes, hypertension, weight gain, immunosuppression, osteoporosis, and impaired wound healing. Before we move on from these drugs, here's an organized summary of the bronchodilators and corticosteroids we just learned about. So you're going to want to make sure you know these drug names. I also wanted to point out that these bronchodilators and corticosteroids are the same exact drugs that are used as part of the treatment in most patients with asthma, not just COPD. So when you learn about asthma later, we're going to revisit these drugs again. Okay, so we learned what the drugs are to treat COPD. Now the next question is, how are these drugs used to treat it? And the answer actually depends on whether we're talking about chronic COPD management or treating an acute COPD exacerbation episode. So let's go through each of these two scenarios now. So let's start with chronic COPD management. So this is someone who is stable, being seen in the office. And the question you're answering here is, what medication is this patient going to be taking daily, basically for the rest of their life? And so the three main goals here are going to be, number one, to reduce the severity of their symptoms. Number two, to improve their functional status and their quality of life. And number three, to reduce their episodes of acute COPD exacerbation. And so the treatment here is going to depend on basically the severity of their symptoms, their response to what the medicine is that they're already taking, and how many episodes of exacerbation they've already had. And there's actually a clinical decision tree that takes all of this information into account. It's called the GOLD criteria, and it basically gives the patient a severity score, and based on that comes up with a treatment regimen. But as a general rule, the initial treatments are typically going to be one or a combination of the bronchodilators, and then if the patient remains refractory or if the COPD is more advanced, then the inhaled corticosteroids are added to the bronchodilators. So they don't replace them, they're just added on. But the most important takeaway here is that systemic corticosteroids are not typically used for chronic COPD management, and that's because of all the side effects that are associated with their long-term chronic use. There are very rare refractory cases where the patient has exhausted all the other options, so these may be considered, but for the most part, as a general rule, chronic COPD management is by bronchodilators and then inhaled corticosteroids, not systemic corticosteroids. So now let's talk about acute COPD exacerbation. An acute COPD exacerbation is an acute worsening of the patient's symptoms, so more shortness of breath, cough, and usually their sputum. It can be caused by allergies, but most of the time it's caused by a respiratory infection, so either a viral or bacterial pneumonia, and it can range in severity. So in many cases, the symptoms are mild and can be handled outpatient, but often they become pretty severe and can even cause respiratory distress or respiratory failure. So this is not a stable routine office follow-up visit that we saw in the last slide. This situation now is much more urgent, and so these are typically patients that we end up seeing in the ER presenting with acute shortness of breath. And so our treatment goal here is going to be totally different than what we saw in chronic COPD management. Now our goal is immediate relief to get us through this short period of exacerbation. So the drugs we're going to want here are the ones that are going to work the fastest and the ones that are the strongest. So for bronchodilators, we're going to use the short-acting ones, so the SAMAs and the SABAs, because they have the fastest onset of action. For steroids, we're going to go with the systemic steroids because they'll have much stronger effects than the inhaled corticosteroids, and that's what we need in the short term to get us through this acute exacerbation. And then finally, we usually also give antibiotics to cover for bacterial pneumonia, especially if the exacerbation is severe enough that the patient is being hospitalized, or if there's high clinical suspicion for bacterial pneumonia. And so in acute COPD exacerbation, we usually don't use the long-acting bronchodilators because the short-acting ones work much faster, and we usually don't use the inhaled corticosteroids because the systemic ones are much stronger. Before moving on to the non-pharmacological treatment, I just have to quickly mention one more drug, which is called theophylline. This is an older medication that was used to treat COPD and asthma, but it's very rarely used now because it can cause a lot of problems, and it's been largely replaced by all the other drugs that we've learned so far because they're much safer. But you may occasionally see a patient that's on it because they have severe COPD or asthma that's refractory to everything else. It's also used more commonly in some other parts of the world, and you also need to know it when taking the USMLE. So here's the quick punchline about this drug. So first of all, it's a systemic drug. It comes in tablet form and it's taken PO, so that means greater risk of side effects because of the systemic absorption and spread. The way it works is that it's a non-specific phosphodiesterase inhibitor, so it decreases the breakdown of cyclic AMP, which means increased levels of cyclic AMP, and as you remember from a few slides back, increased cyclic AMP eventually leads to smooth muscle relaxation, and this is why it can be used in COPD and asthma as a bronchodilator. But it has several major red flags. The first one is its side effects. Because its target enzyme is not specific, it can affect the enzyme in many different organ systems and cause toxicity. The two main ones are cardiotoxicity, so the heart, where it can cause tachycardia and arrhythmias, and then the other one is neurotoxicity, so the brain, where it can cause seizures, and these are very serious side effects of this medication, and they're also very high yield clues on test questions, so you definitely have to keep these in mind. The second problem with this drug is that it has a narrow therapeutic window, which means that its levels have to be closely monitored. And then the third problem is that since it's metabolized by the CYP450 enzymes, it can cause a lot of drug-drug interactions. And so for all these reasons, as I mentioned earlier, this drug is rarely used anymore in favor of the inhaled bronchodilators, which we discussed earlier. Alright, so now that we covered all the drugs, let's wrap up with the important non-pharmacological treatment for COPD. First and most important is smoking cessation. It's the most effective treatment for COPD in improving outcomes. So even though the lung structural damage in COPD is irreversible, stopping further damage at any time can significantly improve symptoms and outcomes. Vaccinations are also important, as patients with COPD are at greater risk of developing respiratory infections. Exercise and nutrition are important for improving strength and breathing mechanics. Since most COPD is linked to smoking, these patients need rigorous screening and monitoring for lung cancer. And then finally, in patients with advanced severe COPD, their lungs won't be able to sufficiently exchange gas, and so they may need supplemental oxygen for their hypoxemia. But one thing to watch out for with oxygen therapy is that these patients over time depend on their low blood oxygen levels as the primary driver for their ventilation. So sudden significant increase in their blood oxygen levels by giving them supplemental oxygen may actually suppress their ventilatory drive and lead to hypercapnia. So this is something to watch carefully and monitor with ABGs. Okay, that's it and that's all. If you want to learn more about these topics, check out the other videos that I've linked here. And if you guys enjoyed this video, don't forget to like, comment, and share it with others. And also subscribe to this channel so you don't miss out on upcoming content. But for now, thanks for watching. I'll see you next time.